Good morning, everyone. I now call this meeting of the Human Services Committee to order, and I want to thank you all for being here. Today, we want to continue our focus on the critical services and supports available to Pennsylvanians living with traumatic brain injuries. Some of you will know that last week we explored the care needs and coverage options for individuals. And today we want to take a deeper dive into the delivery of treatment and the supports available to those affected. And so we're also fortunate to hear from someone who will share their firsthand experience of living with a traumatic brain injury, offering insight into how our policies and our programs translate into helping real-life experiences for Pennsylvanians. And so having said that, let's take the attendance. Ashley, would you please take the roll?
Chairman Williams.
Here.
Rep. Bellman.
Designation?
Rep. Benham. Here. Rep. Serrato.
Designation?
Rep. Harrell.
Leave?
Rep. Green.
Leave?
Rep. Harris.
Leave?
Rep. Kahn.
Here.
Leave. Rep. Kincaid.
Leave?
Rep. Mays.
Leave?
Rep. Auden.
Leave?
Rep. Prokopiak.
Leave?
Rep. Rivera.
Present.
Rep. Vingett.
Here.
Chairman Heffley.
Here.
Rep. Anderson.
Leave.
Rep. Bashline.
Here.
Rep. Flick.
Here.
Rep. Flood.
Here.
Rep. Hogan.
Here.
Rep. Labs.
Leave.
Here.
Oh, I'm sorry.
Rep. McKenzie. Rep. McKenzie.
Leave.
Rep. Pugh.
Here.
Rep. Reichard.
Leave.
Rep. Schlegel.
Leave.
Rep. Weeknet.
Leave.
All right, we have a quorum. As with last week's meeting, today's session is going to feature on 3 panels. And so we've got each panelist, and we're asking you to take 5 minutes to present, followed by designated questions for this session. To stay on schedule and hear from everyone, I'd like to ask that committee members please keep your questions concise, refrain from general commentary. And to our panelists, your written remarks have already been shared, so committee members have them. We'd encourage you to highlight the key points and share any additional insights during your time today. We want to be good stewards of both the testimony and our time. And so once again, thank you all for joining us. Before we begin, I'd like to invite my colleague to share any comments he might have. Chairman Heffley.
Thank you, Chairman Williams, and members of the House Human Service Committee. Thanks for your participating on this important discussion on traumatic brain injuries. As I mentioned last week during the meeting, we all know of somebody with a brain injury who has encountered obstacles in accessing services, and it's critical that we hear from individuals with brain injuries and those that provide the vital services so we can remove unnecessary obstacles and clear the path to improve health. I thank you for being here today, and I look forward to your testimony.
Chairman Heffley, thank you. And with that, we'll begin with our first panel. Please allow me to introduce Ms. Tara Trago, Director of the Department of Health's Bureau of Family Health. Please make your way to the table and begin when you're comfortable. Please, if you would, just pull the microphone down and make sure that it's on.
I'll start again. Chair Williams, Chair Heffley, and members of the House Human Services Committee, thank you for this opportunity to come before you to speak about the Department of Health's brain injury programs. I'm Tara Trego. I'm the Director of the Bureau of Family Health, and I'm pleased to share with you about some of the services that we offer through the Bureau of Family Health. You already have discussed data, and I think you're familiar with some of the statistics, so I won't read this verbatim. But of course, in Pennsylvania, approximately 86,000 individuals are affected by brain injuries annually through visits to the emergency room. Almost 20,000 are hospitalized, and over 2,000 die each year from traumatic brain injuries. So it's important for individuals who sustain brain injuries to receive services and supports.
Ms. Trago, excuse me for interrupting, but I'm going to ask you to bring that microphone just a little bit closer.
How's
you can
that?
even pull it to you a little bit. Okay?
Is that better?
That's better.
All right.
Thank you.
In the Department of Health, we strive to provide services for people who have had brain injuries through a number of state and federal programs that we offer. So I'll share a little bit about the work that we do through collaboration with community, state, and national organizations. And we receive funds both federally and some state funds through the Emergency Medical Services Operating Fund. Primarily, the federal funds that we receive are from grants with the Administration for Community Living. The grant is a traumatic brain injury state demonstration grant. And then we also use some of our funding from the Title V Maternal and Child Health Services block grant for services for children who have received head injuries. In combination with those funds, we have a number of different programs that we administer. One of them is called Brain Steps, which is a return to learn program for students who have had a concussion. And we work with the Brain Injury Association of Pennsylvania for this program, as well as the Department of Education, to help students to have a better experience after they've had a concussion or a brain injury with returning to learn, so that they are maximizing their educational experience as well as addressing any kind of health impacts from the brain injury. We also administer the Safety and Youth Sports program from our Title V Maternal and Child Health Services block grant. This is a program that provides education and training to coaches, parents, athletes, and schools regarding concussion symptoms and resources. And we have a brain injury and opioid training program that provides education and training to professionals within both drug and alcohol fields as well as brain injury fields on the correlation between opioid use and brain injury. We also, I'm kind of skipping around here, but I know you have this written, so I'm not following the testimony exactly. The Administration for Community Living is one of our federal grants that we have, a traumatic brain injury state demonstration grant. Through that, we offer the Neuro Resource Facilitation Program, which I'll talk more about momentarily. And we facilitate a brain injury advisory board, which includes individuals with brain injury, family members and caregivers of individuals with a brain injury, professionals working with individuals, as well as community members and other state entities. The Brain Injury Advisory Board meets quarterly, and they've really been active in directing the work of some of our programs and helping to share information about some of our programs as well. The action plan that the advisory board works from is really focused on improving the competency of the workforce to encounter the workforce that's likely to encounter individuals with brain injury by providing training, education, and technical assistance. They're also working towards increasing knowledge and awareness of available opportunities and resources for individuals with brain injury and enhancing services and supports. So the two key programs that I want to talk with you today about are the Neuro Resource Facilitation Program, or NRFP, and our Pennsylvania Head Injury Program, or HIP. The NRFP is a program that assists individuals who are 18 and older with brain injuries and their family members to identify and navigate brain injury resources, services, and supports. The goal of the NRFP is to help individuals maximize their health capabilities and well-being, and it's provided at no cost to individuals or their family members. The way that this program works is there is a neuro resource facilitator assigned to each individual who's seeking assistance. And those facilitators meet with the individuals and their family members to provide information about local resources, services, and supports, including the eligibility criteria, and help those individuals with navigating and pursuing appropriate services and supports. They can help to create a plan, provide ongoing support over a 6-month period, and finally partner with individuals and their families to ensure that they can continue to access services, resources, and supports after they complete the program. We work with the Brain Injury Association of Pennsylvania to assist with that program. The other program, the major program that we have within the department is called the Head Injury Program, and that was established by the Emergency Medical Services Act of 1985 and is funded by the Emergency Medical Services Operating Fund and pays for head injury rehabilitation services for people who qualify. The eligibility criteria are based on Pennsylvania and U.S. residency, having sustained a traumatic brain injury after July 2nd of 1985. They must be 18 or older and meet income guidelines, which are currently less than 300% of the federal poverty guidelines, and complete an application. And most importantly, one of the main eligibility requirements is to have needs that are able to be addressed through rehabilitation by the HIP. Our goal is to assist individuals to live independently in their homes and communities. It is intended as a short-term program, and our individuals who are enrolled may receive no more than 12 consecutive months or $100,000 for rehabilitation services as specified in their individualized service plan. They are eligible for an additional 6 months of case management, or about $1,000, to assist in transitioning out of the HIP after the initial enrollment period. The services that we provide through the program include pre-enrollment assistance, pre-admission assessment, a service plan development, and rehabilitation to address individual needs such as nursing care, assistive neurobehavioral therapy, assistive community integration, work skills services, psychological services, and cognitive, occupational, speech, and physical therapies. There are other additional services beyond those that are provided and eligible for the program based on the individual's needs, and case management as well. These services are provided in residential facilities, outpatient facilities, and other home and community-based settings. The HIP currently contracts with 9 specialized brain injury programs throughout the Commonwealth to provide services to HIP clients, and providers are required to maintain appropriate state licensing as well as licensing through the Commission on Accreditation of Rehabilitation Facilities, or CARF. So in conclusion, the Department of Health, in cooperation with various partners and stakeholders within the brain injury community, is committed to enhancing the lives of those living with brain injuries by providing rehabilitation, education, awareness, and advocacy. While our department's brain injury programs are currently funded through a combination of competitive federal grants, our Title V Maternal and Child Health Services block grant, which is not competitive, and state funds, there are needs for individuals with brain injury that cannot be met through our current programs. And we welcome the opportunity to discuss more about what the department could be doing. Thank you for the opportunity to be here today, and I look forward to answering any questions that you may have.
Ms. Trago, thank you for your presentation. I want to acknowledge we've been joined by Representative McKenzie and Representative Serrato. At this time, if the members have any questions for Ms. Trago.
First, thank you for your testimony. As a survivor of a brain injury, I greatly appreciate it. One question: how would my constituents or everybody's constituents across the Commonwealth become more aware of your programs? Or what are you doing now? Because I guess I want to focus on this. Mm-hmm. Thank you.
Yeah, that's a great question. We do have some printed materials. We have tip cards that we try to have placed throughout hospitals, brain injury providers, some of our specialist partners, especially in conjunction with our brain injury advisory board. We try to get that information out. We have our information is of course on our website and in various resource guides. And we have a brain injury helpline that we staff at the Department of Health to provide information about these services. I will say that we don't have any like allocated funding for promotion, media outreach, that kind of thing. So our ability to widely broadcast the information is somewhat limited, and we do rely a lot on our stakeholders and our partners to share the information as well.
Okay, thank you. Thank you, Mr. Chairman.
Any other questions? I have one. Ms. Trego. Oh, Representative Labs?
Thank you, Mr. Chairman, and thank you for your testimony. I have a lot of questions here, but I'll keep it concise. You mentioned that the Brain Injury Advisory Board. My ultimate question is, are there any veterans on this board that are, addressing the veteran population that has acquired brain injuries?
That's a great question. I actually don't know off the top of my head. And I know that there are a number of people who are individuals who have sustained brain injuries. I know that veterans is not a one of the designated positions that we try to recruit for. So I don't want to speak incorrectly. There probably are, but I'm not absolutely certain that there are on our advisory board.
Can I just ask a follow-up as to why that's not a position that's recruited for?
So the positions that are included within our advisory board are, this is something that is a requirement of our federal grant. So it's not part of statute or regulation. And so we follow the guidance from our federal grantor, which is the Administration for Community Living, on the positions to be filled for the board. It's certainly something that we would have the flexibility to make sure that that would be included and that voice would be represented. But again, I don't want to speak incorrectly, so I'm just not positive that that is specifically one of the positions that is required.
Yeah, no, I appreciate it. I'll follow up with you with any additional questions on that. I just think as a whole, it's really important. We have a veteran population that these traumatic brain injuries greatly affect, and we need to make sure not only that they're represented, but that they're able to access the treatment and the care that they need. So thank you very much.
Thank you.
Thank you. We've been joined by Representative Frio-Otten. I just want to make sure I'm not missing any questions by the members.
Chairman, I have a question.
I'm not sure, was that Representative Kincaid?
Yes.
Representative Kincaid to be followed by Representative Pugh.
Thank you. Thank you for joining us. I have a question about how you work potentially with the Department of Corrections, as we are, continuing to see a crossover of people with traumatic brain injuries and the criminal justice system. If you are working to get, and I would guess with your programs, it would impact more returning citizens than folks who are actively incarcerated, but connecting them with these kinds of resources.
Yeah, so again, people who are returning could certainly qualify and receive services through the Neuro Resource Facilitation Program. We are not actively working with the Department of Corrections at this point, but we have, through some of our historical funding for the ACL federal grant, that's, as I mentioned, that's a demonstration grant, so the guidance and the priorities on that grant change from grant cycle to grant cycle. And previously, one of the priorities was related to juvenile justice. And so a lot of the work that that we do on the side of the federal funding is related to our federal funding priorities. And so there had been some work that we were doing with juvenile justice providers and the Department of Corrections in that regard, but that's not one of the active priorities that we have with the funding at this point.
Okay, and I guess sort of related to Representative Ladd's question, when it comes to the advisory board, do you have anyone, or I guess you probably don't know off the top of your head, but could you get me the information as to whether or not you have anybody serving on the advisory board who has been incarcerated or experienced incarceration?
Yeah, I can certainly get that information for you, and I don't know off the top of my head, and it's not something that we would ask, but would certainly, if an individual who is representing themselves as a person with a brain injury has had that experience, that they would be open to sharing that.
Okay, thank you.
Thank you, Representative Pugh. And let me remind the members, in the interest of time, if there are additional questions that you'd like to ask, submit them to Imogen or to Anne Marie, and we'll make sure we get answers to your questions. Representative Pugh.
First, I want to thank you for coming today and answering our questions. I do have a quick question. I'm going to fall back. Having somebody who does have a TBI, and it's a combative TBI that came back from war, we found that in the hospital there wasn't too much knowledge on where to send him, what to do, any outsourced resourcing to get him the help that he needed when he had an incident once he got home. Is there a way, or what would your idea be, to get that information into the hospital so they're more aware of the situation and where that they can, focus these people to go to get the help that they need?
Yeah, that's definitely a topic that we hear a lot from the Brain Injury Advisory Board. Numerous stories similar to that, whether it's the hospital or the emergency department, that people are struggling to receive the follow-up and just the inpatient care that they need based on some of the lack of information that the providers have. So that is something that we're trying to address through the limited resources of the Neuro Resource Facilitation Program. The Brain Injury Association of Pennsylvania also has some helpline support that they can provide more additional information for the specialized communities or providers in communities, as well as there are just some efforts in general that the Brain Injury Advisory Board is working through to increase the just general training and technical assistance, some resources. One example that we have worked through recently is we've developed some toolkits and essentially like a one-pager sheet for emergency departments or for other first responders and others who may be working with someone who, whether they have had a concussion or have had incidents of intimate partner violence or other kinds of issues, that they would be receiving services through the EMT, that there are some additional training and technical assistance for them to be able to provide those resources right away. So I agree with you. It is a need, and there are definitely things that we would like to do. We are somewhat, again, limited by the staffing and the constraints of our funding to be able to offer some of those services, but through our networks with the advisory board and some of our hospital partners are certainly aware of opportunities to get those resources in place.
Ms. Strigo, thank you so much. Moving towards our next panel, I'd like to invite Penn State's Health Department, Physical Medicine and Rehabilitation. I'm going to ask Dr. Thiru Anaswamy, Professor and Chair, and Dr. Lori Grafton, Assistant Clinical Professor and Co-Director, the Brain Injury Fellowship, if you'll make your way to the table. And as soon as you're comfortable, please, Dr. Anaswamy, begin. Good morning. Would you also pull the mic just a little bit closer? Right.
Thank you, Chairman Williams, Chairman Heffley, the members of the House Human Services Committee for inviting us and to participate in today's informational hearing on the treatment and support for traumatic brain injury patients. We are pleased and incredibly honored to share our background on this topic, specifically as it relates to Penn State Health's Brain Injury Rehabilitation Treatment Program and our Brain Injury Medicine Fellowship. We will talk about, in our background, the specialty of physical medicine rehab, an overview of the brain injury medicine subspecialty, the treatments available to our patients, coupled with associated challenges that all of us face, including our patients, caregivers, staff, faculty, healthcare professionals, throughout this journey that patients with traumatic brain injury undergo while navigating not only through the healthcare system but beyond. We'll briefly discuss the intersection of traumatic brain injury and opioid use disorder. But first, on the background, physical medicine rehabilitation is a medical specialty. PM&R physicians, as we are known, also known as physiatrists. We treat a variety of medical conditions affecting brain, spinal cord, nerves, bones, joints, ligaments, muscles. We are essentially medical specialists that rehabilitate people after injury or illness. The subspecialties under physical medicine rehab include traumatic brain injury or brain injury medicine, neuromuscular medicine, pain medicine, sports medicine, stroke, etc. Brain injury medicine itself includes disorders of brain function due to injury or illness. These disorders have physical manifestations, cognitive, sensory, behavioral, psychosocial, educational, and other vocational consequences, as you've heard throughout today and last week. A specialist in brain injury medicine, which is an American Board of Medical Specialties subspecialization under physical medicine rehab. It has special expertise in the management, evaluation, and management of these disorders. We have 3 such board-certified brain injury medicine subspecialists in Penn State Health here in Hershey who provide care for these patients. We also have a brain injury medicine fellowship program that accepts those who have completed their postgraduate medical training for a 1-year fellowship. And these fellowships are fairly limited. There's only 31 of them around the country. 4 of them are in Pennsylvania, including the one in Hershey. They, the fellows, train in medical management, rehabilitation, as well as follow-up care, including coordinating with other resources in the community to help the patients get back to their communities. They participate in research to better understand how to improve the care they provide these patients in the future. And then they go on to become directors and follow up, continue to provide brain injury services to patients to wherever they choose to practice.
Is it on now? Okay, excellent. Thank you so much for having us. So I'm just going to expand a little bit on what I do. I'm a brain injury fellowship trained physiatrist, and we really treat brain injury patients across the continuum. So to speak to what one of the members had previously asked, we provide consultation services both in the ED and in the acute care hospitals. The problem is there aren't people like me everywhere, right? But we are working to educate our ED physicians. We have worked closely with our trauma services, specifically at Penn State Health, on when to make referrals for our services to really bridge that gap. So I personally see patients over at Holy Spirit Hospital and Hampden Hospital who have suffered injuries. We help manage them while they're there. We help the other teams who may not really understand brain injury, right? And then we help move them on to the next steps, whatever's appropriate for those patients, right? So, and it depends on their functional status. It unfortunately depends on their insurance coverage. It depends on their family support. There are many, many factors. It's not just about the injury and what this patient should get, unfortunately. But we do try to help them get to the right next level of care. For a lot of us, we also work in acute rehab facilities, which are inpatient rehab hospitals. That would be the most intensive type of rehab, and so those patients would come and stay with us for several weeks. They would get about 3 hours of therapy a day. They would have somebody like me seeing them. They would also work with our neuropsychologists, our case managers, to really help get them as much recovery as they can, and also to help set them up, hopefully, for success as an outpatient. Some patients can't get that level of care for a variety of reasons, right? Some patients need to go to subacute nursing facilities because maybe they can't tolerate the 3 hours of therapy yet, right? Maybe, unfortunately, they don't have insurance benefits for acute rehabs. I can't tell you how many peer-to-peer discussions I do on a weekly basis trying to advocate for our patients. Luckily, some patients do recover better, right, and are able to go home and benefit from outpatient services or home health services. And so we also help with that. And so it's really our job to help people navigate that system as much as we can within the confines of what we're able to do. A big portion of what I do is also this outpatient long-term follow-up. So for many of my patients, I see them for the rest of their lives. So I see them pretty frequently initially, and then we kind of space it out. I saw a patient yesterday who's about 2 years out from his injury, and so we're spacing things out to about 6 months now because things are a little bit more stable. But we're still talking about things like mood, balance, his interaction with family, right? So there's a lot of things long-term that still need to be addressed by a physician, and so that's a lot of what we do. In speaking to some of the other questions in terms of how we access some of these other resources, our social workers are key to this. We really rely a lot on them to help us identify these resources, whether patients are eligible for the head injury program for waiver services. Unfortunately, as you've heard, the head injury program specifically is only for traumatic brain injury. So for my patients who have suffered a noxic brain injury or other acquired brain injury, they are not eligible for those programs. And so that leaves it to families to fund any kind of things that would not be funded by insurance. So there, I think, is opportunity to expand some coverage to some other acquired brain injury. The other thing that I'd really like to make a point of, which is in our testimony, is the need for psychological support for these patients. As we know, it is very challenging to obtain mental health right now. It's even harder for my patients who suffer from some cognitive impairment, right, and may not benefit from traditional therapies. They really need psychologists and counselors with understanding of how these patients' brains work and what might need to be adapted to make them successful. So we have some, and it's getting better, right? And we do a lot of education on that. So a lot of our neuropsychologists will provide education for psychologists in the community. But there's definitely a paucity of resources in that area for our patients. Happy to take any questions. Oh, you have.
I'll just follow up to say, before coming to Hershey, I was at the VA, where I had the opportunity to understand how a coordinated program such as the polytrauma services in an integrated health system, obviously, but can be how beneficial that can be to servicemen and women who have sustained brain injury, whether it's combat-related or somehow in service. Also, another anecdote I wanted to share is we do rely on the graciousness of philanthropy to provide a lot of services to our patients. Jackie Lithgow Foundation is an example. We recently received a research funding support from Jackie Lithgow Foundation. Jackie Lithgow himself is a survivor of brain injury, and in his struggle to return to his community and previous life after suffering brain injury, he and his friends cobbled together and fundraised a lot of money to support other brain injury patients such as himself. And that's just a shining example of how, community comes together to support each other and to support departments like ourselves to help others.
Well, I want to thank you both for your testimony. I do have a question because I think it was mentioned in your testimony, Dr. Anaswamy, and I could be wrong, Doctor. The intersection of brain injury and substance abuse. You noted that substance misuse is both a risk factor for brain injury and a reoccurring challenge post-injury. How can brain injury treatment programs better integrate substance use disorder care, and are those opportunities to incorporate brain injury diagnosis and treatment into drug and alcohol programs?
Amazing question. Thank you for bringing that up. I apologize I didn't speak to that. So it actually piggybacks a little bit off the mental health challenges that I have found. Many of our brain injury patients don't benefit the same as a non-brain injured patients from your classic substance abuse programs, right? So there are very classic means of counseling that are employed in those programs that some of our patients, because of their memory or their executive functioning deficits, are not able to benefit as much from. And so that's where some additional training and, I guess, comfort level with working with our brain injury patients can be helpful. But also many patients turn to substance abuse to treat some underlying mental health challenges, right? So I have a lot of patients who have undiagnosed psychological issues that we discover or kind of discuss after their brain injuries. And so with appropriate treatment, many times they are able to abstain from some of the substances, but that relies a lot on patient understanding, family support,
Yeah.
right? This kind of ongoing support for those patients.
Thank you. Thank you. Representative Venkat.
Thank you, Chair Williams, and thank you to Dr. Anaswamy and Dr. Grafton for your testimony. Something you mentioned really struck me as an emergency physician, this issue of we see plenty of patients with closed head injuries and traumatic brain injuries, but most of the time, those who are discharged from the emergency department are being referred back to primary care physicians, which I think is likely appropriate. But I'm curious, in our role here in the committee and looking at this issue, do you think there is a need for government to publicize pathways for saying, okay, these patients should go back to their primary care physicians, these patients likely need referral to subspecialists such as yourself, and how would we do that? And it kind of piggybacks on DOH's program as well, as this is where the rubber hits the road of patients who are being seen at their time of injury and getting them on the right pathway very quickly.
Right. So yes, very astute observation. So there are two issues. So I don't disagree that going back to the primary care may be the best option. The challenge that I have seen is that sometimes that does delay referrals to other things, right? So some primary care physicians are very well-versed in how to access resources. Many of these patients require referrals to specialized therapies that their primary care physicians may or may not be aware of. So we have actually, again, worked to educate both our ER docs and our trauma docs on, hey, just send them to me. Even if I just see them once and clear them, I'm happy to do that. But again, there aren't a lot of me, right? And so it does fall on a lot of primary care. But I think additional education to the primary care physicians of, if you are seeing A, B, and C, you probably want to send them on, right? Or at least start the ball rolling with some therapies, right? But so there may be a role first for a kind of pathway or guideline, yeah.
Thank you, Chairman Heffley, and then he'll be followed by Representative Kincaid.
You talked a little bit about substance use disorder and opioids. Are there specific, years ago they adopted prescribing guidelines. Are there specific prescribing guidelines for people with brain injuries that, or do we need to look at that, I mean, and how we prescribe those medications to that population?
So I will tell you, as a provider, I am very judicious about my prescription of controlled substances to a patient with a history of substance use disorders. We have lots of other ways of addressing things that do not require controlled substances, to the point where I even may prescribe different neurostimulants to a patient with a history of substance use disorder, because the last thing I want to do is make something worse. So I'll give an example. I have a patient, we use a lot of Ritalin in brain injury patients for attention disorders. That's a controlled substance, can be used for abuse, right? We do contracts with our patients and their families to make sure who's managing the medications, so that we make sure we're not making anything worse. Now, are there times when our patients require stronger pain medicines? Absolutely. But it needs to be monitored very closely, and there needs to be commitment from the patient and ideally the family on how that's going to be monitored.
Representative Kincaid.
Thank you, Mr. Chairman. I think that there's going to be a theme to my questions, but I think it's important. So we're consistently talking about how medically important or how important it is to have the medical intensity of treatment. So I'm wondering if either of you have ever worked with the Department of Corrections or know anybody who has worked with the Department of Corrections to train their medical staff on being able to identify these kinds of injuries and treat them appropriately in the same way that, Dr. Grafton, you were just describing about being very intentional, intensive about the way that you kind of address that.
Yeah. So I think there's two parts to it. If I see them in the hospital, so I see a lot of patients who have been involved in injuries, accidents, some of which they are at fault for, right? And so Department of Corrections may be involved for a variety of reasons. On those patients, if the eventual destination is jail, We typically do as much as we can while they are in-house to help with things, get them set up on an appropriate medication regimen, get any therapies that they need. But once they are in jail, it is, we have not necessarily had a lot of work in that space. We have had some challenges in terms of within the Department of Corrections being willing to administer certain neurostimulant medications, so that you bring up an interesting question with that. I also don't know the availability of therapies within the Department of Corrections, so that would be important for me to understand what is available in that setting. For many of our patients, because of the severity of the injury, they end up not needing to go to jail because it's thought that they would require too much care. And so for those patients, they are treated just like any of our other patients and would be afforded all of the same resources. Does that answer your question?
Yes, thank you.
Okay.
I will add to talk about hidden disabilities. Many of the patients with brain injury have hidden disabilities. To improve awareness and better understanding of the kind of interactions and treatments they need, there is the program called the Sunflower Program that we are trying to pilot in our clinic. Sunflower Program can be as simple as having a lanyard or some sort of ID card that allows people that interact with them in a probably in a healthcare setting or other settings, where they can then say, okay, this requires a special attention. Maybe it allows people to understand a better scripting, better awareness and sensitivity to their disabilities, particularly unique disabilities that are hidden, that can be obviously seen by people that interact with them.
Dr. Anaswamy, Dr. Grafton, thank you for your testimony today. Enlightening for sure. We appreciate you. Thank you. Our next panel, I'm going to ask Kristen Ferry, Executive Vice President of Policy and Strategy, if she'll make her way to the table. And I think Elaine Masters is with us virtually, or is she here? Virtually, all right. Ms. Ferry, when you're comfortable, you may begin.
Good morning.
Is the green light?
There we go. There we go. All right, good morning. Thank you, Chairman Williams, Chairman Heffley, members of the committee. Thank you so much for your attention to this important issue. I know the brain injury provider community is really excited about the focus that you're shining on these issues. We've been, for a long time, wanting to talk about them, so thank you for this opportunity. My name is Kristen Ferry. I'm Executive Vice President for Policy and Strategy at the Woods System of Care. The Woods System of Care is a population health organization of 12 providers that provide services to people with autism, intellectual disability, traumatic brain injury, and behavioral health challenges. So across our network of 12 providers, we serve about 50,000 people in New Jersey and in southeastern Pennsylvania. One of our programs within that network is our Beechwood Neuro Rehab program, which specializes in serving people who have survived brain injuries. And the majority of the folks that we serve are in the residential rehabilitation CHC services. And I just want to say quickly a ditto to the other providers and that you've heard from already, and to Richard Edley from RCPA who spoke last week just really about the importance of a budget increase for these services. We have not received an increase in the CHC funding for brain injury in about a decade and a half, and we're definitely lagging behind. This committee is very familiar with lots of folks from human services and healthcare provider communities saying we can't adequately pay our staff. The funds are not there. But I assure you, especially in our case, it's not a Chicken Little situation. We've already started to close programs. There's fewer brain injury providers now in Pennsylvania than there were 10 years ago. I think we had 18. Now we're at 14. At my program at Beechwood, just in the last 2 years, we've had to close 4 of our homes that had some of our highest acuity CHC clients living in them. That resulted in discharging about 10 people. Of those 10 folks who we've unfortunately had to discharge, some of them are in nursing home care now, and some of them are living with their families not receiving rehabilitative services. As a mission-based organization and a nonprofit, it breaks our heart to have to make those decisions. But you'll see in my testimony that with the rates the way they are, we're losing about an average of $150 a day per CHC client in our program. And the CHC doesn't cover a lot of the services that those clients need, especially as they age in place and those needs can increase. But if you'll indulge me for just a second, I do want to take the rest of my time to just really highlight why these services are so important and why getting survivors in the appropriate services are so important. I told a story in my written testimony about my friend Mike. He was a Beechwood client who came to us in 2020. You guys would have loved Mike because he was a Politico guy. He would have talked politics with you all day. He had a quick wit, was super sharp, really sarcastic. He was a joy to be around. Prior to his injury, he was working in Philadelphia City Council. Unfortunately, one evening in 2015, while leaving a political event in the city, he was the victim of an assault. And he was hurt so badly during that assault that he had a number of physical injuries in addition to his traumatic brain injury. For the first 5 years after Mike's injury, he experienced what a lot of survivors do, being bounced and forth from rehabs to nursing homes, trying to get into appropriate rehabilitation facilities, but just really struggling to navigate the service system. He found Beechwood finally in 2020 and came to stay with us in August 2020, and he was our most vocal cheerleader about the change that made in his life. In the 5 years that Mike was in nursing home care, he felt that he was by far the youngest person there. He had his injury when he was in his early 50s. He experienced significant depression in that setting. He was not able to leave the nursing home facilities, didn't have a lot of social interaction, didn't have a lot of peers. I know when I was speaking to our admissions team, they were really touched that when they started to meet with him for admissions to Beechwood, they asked him what he wanted to do if he got to Beechwood, and his response was he just wanted to go to the movies. He didn't have the ability to go to the movies. He was able to go through, the basic screenings that we have for clients to gain more independence. So Mike eventually, he was wheelchair bound, but he was able to, on his own, ambulate into the community. He was able to start attending church. He was able to go to the park, go to community events, and he was just constantly very vocal about the difference it made in his life that he was able to regain some of those skills by getting appropriate services and getting, some cognitive rehabilitation and, not just sitting day by day in the nursing home. So I wanted to share Mike's story today because he founded an advocacy committee when he was at Beechwood, and he cared very deeply about advocating for these issues. And if Mike were still with us, unfortunately he is not, but if he was still with us today, he would have done a much better, more articulate job of telling that story than I just did. But I do hope that I'm doing him proud and illustrating to you folks that I hope we can find ways to be innovative. I hope we can find ways to make sure that folks with brain injuries who are not currently getting appropriate rehabilitation services may be able to do that, even if they are in a nursing home. I think there are ways that we can provide integrated care and try to make sure that they have access to the appropriate services. So thank you for your time, and I appreciate, again, the attention to these issues.
No, thank you, and I appreciate the story. Let me ask you a question. I heard you cite facility closures as well as discharges, so I'm curious to know, do you have any idea how many residential brain injury services are available to Pennsylvanians?
That's a great question because there's a big need for data in this field. So I think last week we heard folks cite a number of 450 people, and then we heard other folks cite a number of 600. So I don't know with any certainty. I know that I am one of the larger, I'm not the largest brain injury provider, but we're one of the larger ones, and we have 100 people currently in our program. But I really think that illustrates the need for why we certainly need a short-term budget solution to just make sure we can continue to provide services. But longer term, I think a study would really benefit this industry so that we can see if there are ways to be innovative, look at what other states are doing, and get a handle around what are those numbers? How many people are waiting? How many people are in services?
Thank you. Thank you. Representative Flood.
Thank you. Last week at the hearing, well, you had stated in your testimony that there were 500,000 people here in Pennsylvania that have sustained a brain injury. And last week, I asked the question in the hearing about whether there was a wait list. I was told that there was no, but then in fact later, when there was another testifier, they had said that there, in fact, would be a wait list if, some of these individuals were able to be assessed to find out that they actually do need these programs. So can you elaborate a little bit more on that? Are you finding that there would be a wait list for these programs if there was, the proper assessments needed? And then also, the second part of that question is actually when it comes to funding, because the overall arching theme here is that there is not enough funding for this. And I know that there used to be a line item for brain injury in the budget, which is now moved under CHC, hidden in, is it residential habilitation? And do you find that the funding is not actually making it down to those programs? And do you feel that a change in the fiscal code for short-term might be giving you the funds that you need? That's something that we can do as legislators, we can advocate for. And long-term, do you feel that we should be advocating for a line item again in the budget for you guys?
Sure, thank you.
Because this is very important.
Yeah.
There's a reason why we're having 2 hearings on this.
Absolutely.
So.
No, those are wonderful questions. And, I'll start with your waitlist question. I think I really liked Richard Edley's quote last week where, there's just a wait list for the wait list, because it depends how you determine wait list. I would be of the opinion that if somebody is in a nursing home improperly and not getting cognitive therapies that would benefit them and help them regain skills that may even allow them to do things like return to the workforce, I would say that's a wait list. And we certainly know that there are folks that are in nursing homes, skilled nursing facilities, not getting any of these therapies because that's where we get our referrals from. So I know they exist, and I personally would consider that a wait list. And I'm certainly also not saying anything negative about the nursing homes. We have wonderful ones in this Commonwealth. But if you're an individual who is 30, 40, 50 years old and has a brain injury, and you're surrounded by folks who are senior citizens, I don't know that it's the most appropriate location for you. So I would say that to me counts as a wait list. I think officially, since those folks are receiving care and they're in a nursing home setting, that perhaps some others don't consider that a wait list. Your question about the line item is a really good one, because the conversion of these programs into CHC predates my time a little bit with Woods, so I wasn't there when the advocacy related to that change was made, but I can certainly say that we have felt that we get lost in a large, I think with the federal match, it's like a $4 billion line item, CHC for the Commonwealth, and we're such a small percentage of that. Part of the challenge has been ensuring, even when we're asking for increases, to help articulate to the legislature how you direct it and make sure that it gets to us and not one of the many other programs that are funded by the CHC line item. So I would certainly be of the opinion that I don't know if it could be immediate a solution that we carve us out or give us a dedicated line item again, or if that's a longer term strategy, but I would certainly be a proponent of that. I think that would be really helpful. We do feel like we get lost in this gigantic line item.
Thank you, Ms. Fair. I'm going to ask you to remain at the table, and we've got 2 other presenters with us virtually. I'm going to ask if Ms. Elaine Masters would provide us with her testimony and then be followed by Victoria Harding. And again, I'll ask you if you'll just compress your comments in the interest of time and begin with you, Ms. Masters.
Elaine, we can't hear you.
Why don't we try then to move to Ms. Harding and circle back?
Absolutely. Thank you very much. Good morning, and thank you, Chairs Williams and Heffley and members of the House Human Service Committee. I appreciate the opportunity to provide testimony at today's informal hearings. I'm here on behalf of Neurorestorative, a specialized brain injury rehabilitation provider here in Pennsylvania. Neurorestorative also operates neurorehabilitation programs in 25 other states across the country. I'm Dr. Victoria Harding. I live in Wyomissing, Pennsylvania. I'm a speech language pathologist, a cognitive neuroscientist, a certified brain injury trainer, and for the past 33 years. I've been fortunate to serve people recovering from brain injury in many different brain injury rehab support and service provider settings. I'm currently the Vice President of Development with my company, and I can say that myself and my colleagues in this provider group here today are truly honored to get to do this work of neurorehabilitation with people during some of the most challenging times of their life. We are so grateful to get to support people to live well after brain injury, to return to their life and their communities, and to enjoy life satisfaction here in the Commonwealth. And we do appreciate being able to provide medically necessary brain injury services for individuals under the Community Health Choice Waiver. And you've heard from many people over these 2 days, we need your help. Because of community choice reimbursement, we operate at a loss when we provide services under the CHC waiver. People who do this work need to be paid, or we can't do this work. My written testimony has some examples of the rate disparity with other state funding sources, so I invite you to please consider that. We deliver medical services with a specialized workforce. This is why it's important to fund who we are educationally ensuring are prepared and are trained and are skilled in supporting people who, due to their brain injury, require a specialized environments of care that our staff create in order to relearn life skills. And it's because the people we serve have challenges in their life functions, like understanding instruction or maybe communicating wants and needs, or solving everyday problems or challenges in their everyday behavior. This takes a specialized trained workforce to do this work, to regain life skills and to increase the safe independence to live in our communities and to adjust to their changes in abilities. And regardless of if people sustain their brain injury as a result of a fall or a motor vehicle accident or an overdose or a stroke or through domestic violence or maybe a sports injury, when a person with a brain injury is able to access specialized brain injury rehabilitation, the right rehab at the right time, as Dr. Nagel stated a few days ago, they have an opportunity to avoid a lifetime of costly long-term care support needs. Our brain injury community research really shows that access to specialized care reduces the burden on our healthcare system. So the treatment and ongoing support that we as providers are ensuring is delivered reduces rates of return to hospital. It drives down the frequent and costly emergency department visits. It really assists in managing the often costly co-occurring medical diagnoses that we see people present with, things like diabetes and seizure disorder or infection or headache or anxiety and depression. Our supports and services can reduce some of those high-cost polypharmacy and drug interaction complications and really support people to live in their own homes, in their own communities, to avoid a lifetime of expensive institutional care. So we are continuing to experience staff shortages, and the shortfalls in funding, even for people who we are serving, they don't always get delivery of all the services that are part of an individual's person-centered plan. And we have many examples of that. So I just want to underscore that the lack of funding is really chiseling away at our ability to maintain a skilled workforce and is eroding access to specialized services that are provided for people with brain injury in the Commonwealth under the CHC reimbursement. So people who help people heal from brain injury need to be paid more than they were paid in 2013. So we ask that we please address the CHC funding shortfalls by supporting the brain injury provider state budget request for the $13 million investment. I know that the federal matching is going to bring the state's total to 30 million. These funds are desperately needed to allow providers to continue to operate in the Commonwealth and to improve care, address some of the staffing shortages, and provide stability for the critical services here in Pennsylvania. So would love to hear comments or any questions.
Ms. Harding, thank you for your testimony. Let me do this. Let me try to circle back to Elaine Masters. And Elaine, if you could unmute And let's see if that works.
Can you hear me now?
Indeed we can. Thank you.
Wonderful. Okay, thank you. And thank you, chairs and everyone here for the opportunity to address the committee. So a little about my experience. On November 12th, 2015, I took a nosedive down my basement stairs. I bounced off the wall on the right, hit the wall on the left, landed on the top of my head, and came to sometime later in an upside down tangle. When I opened my eyes, I couldn't remember what day it was. At the time of the injury, I was self-employed as a writer and editor, operating at a high intellectual level. It was a powerhouse. While I understood that I had been concussed, I had no clue that on a dime, the life I knew was gone and that I had lost my brain, the very thing that made me tick. I loved my work and I tried to push through the challenges of my brain injury. The first sign of my TBI was having to take my glasses off to read a book. Next was my struggle using a computer. It took me half an hour to type a few sentences. I couldn't fill out forms or process what I was reading. Mail piled up. I couldn't remember to eat or shower. At the grocery store, sensory stimulation was overwhelming. I'd stare at the dairy aisle shelves looking for ricotta cheese until I gave up, left my groceries, and went home empty-handed. I lost my business. I lost most of my family and friends. They couldn't understand what was wrong with me. To be honest, neither did I. I thought I was losing my mind. No exaggeration, I was close to either living in a facility or being homeless. If I hadn't been so tenacious, I wouldn't have survived. Between 2017 and 2019, I was diagnosed with an inner ear concussion and persistent concussive symptoms, a condition where symptoms continue beyond the expected recovery period for concussion. One challenge is that I can't efficiently and accurately process sound traveling from the inner ear to the brain. I might hear what you're saying, but it hasn't sunk in. I'm still trying to figure out what you just said. You've moved on to another topic. Living with a TBI is like being picked up by aliens and dropped in a parallel universe. Nothing has ever been the same. It's been like living in a funhouse where the floor tilts and mirror reflections are distorted. That was the state I was in when I needed to find a new PCP, when I needed a referral to a concussion clinic, when I needed to apply for Medicaid and disability, when I needed to enroll in the Pennsylvania Head Injury Program. I was accepted into that program in late 2018 and finally received cognitive rehabilitation therapy, which has been integral in helping me relearn and manage activities like shopping for groceries, planning and making meals, managing medications, getting to appointments, receiving assistive technology to regain computer access because my brain shuts down from screen flickering. Imagine trying to survive in this technology-based society without computers, no Googling, no emailing, no printing materials from websites. Unfortunately, the low pay rates, as Tori mentioned, for these highly trained cognitive therapists causes high turnover that results in gaps in coverage and setbacks in my progress. Most people don't have my tenacity. They give in or give up because of the difficulty accessing benefits. Increased funding for brain injury would allow programs to offer full services so people will be able to get what they need when they need it. My nearly 6-year-long struggle for home modifications exemplifies the challenges in accessing benefits. Traversing the sloped and uneven steps and walkway to my front door, from my front door to my car, or the 2 flights of stairs in my house to do laundry would shut down my brain for a few hours or a few days. The process of applying and dealing with denials and all the levels of appeal was arduous. Instead of managing my own care, I spent massive amounts of time working with Pennsylvania Health Law Project to get approved. Lengthy meetings with my MCO resulted in my falling and reconcussing myself several times. When their attorney, my MCO's attorney, finally read the evidence, he agreed I was indeed entitled to the benefit. There has to be an easier way. Be aware that the choice to not fund services allowing for treatment sooner will not save money, but rather result in the need for a higher level of spending later on. Sadly, the opportunity for a person to heal and be a more productive member of society will be greatly diminished. Based on the progression of my symptoms, had I been diagnosed or treated sooner, had I received services sooner, had the process of being approved for services been less arduous, I believed I would not have devolved to the level of health I now live with. I continue to have numerous problems with things like balance, vision, and cognitive functioning. And it's unlikely that I would require as many supports as I do now if I had gotten, to quote Drew Nagel once more, the right care at the right time. Thank you so much.
And Ms. Harding, thank you. I'm wondering, do we have any questions for any of our panelists? Okay, Representative Flood.
Thank you. This question is for Ms. Harding. We had talked previously here in the hearing about people who are being placed in nursing homes but not getting the proper rehabilitation that they need and access to the services that they need. And we know the skilled nursing homes are very costly. Is there a cost savings to having a brain injury patient in a residential rehabilitation program rather than a skilled nursing program?
You know, that is a great, I think, question to consider if the committee, and it does appear that this is a committee who's very interested in chronic disease. Brain injury is a chronic disease process, and the CDC recently recognized brain injury as a chronic disease process. So, I think that is a great question to specifically for the Commonwealth, and we've seen this in other states as well, that this question be asked. But please do consider supporting a joint state government commission study to evaluate the long-term needs of people who present with brain injury. I think an independent study could provide some of those critical data related to the provider capacity and the service costs and the wait lists and the workforce wages and those interesting funding streams that the Insurance Trade Association and Highmark were discussing a few days ago, and the number of individuals receiving only some of their needed services and how some of that may interplay with our nursing homes in the Commonwealth. I think we also need to look at the ability to seek Medicare reimbursement for the dual eligibles, which was a topic that was broached earlier. So great line of inquiry that we are also interested in exploring.
Representative, thank you. I do have a question before we begin to wrap up. I'm just curious. Do any of you have any examples of essential services that are not being reimbursed?
I certainly would be happy to provide a couple of examples. If given the opportunity to expand our workforce, we will certainly work to fill vacancies to serve people who are experiencing services, who are seeking services. But we want to expand the types of services that are provided. So, for example, Neurorestorative previously provided behavior therapy to help people who had experienced behavior discontrol after their brain injury, but CHC does not at this time reimburse at a rate that supports the hourly rate for a certified behavioral therapist or a behavior analyst. So these people are left untreated and supported, then they will be served elsewhere in our hospitals or our criminal justice systems. So that's one example. We also know, I think people here have included in their testimony, an opportunity to expand services in areas of the Commonwealth that are chronically underserved and are in need of support in certain geographies.
I would just add to what Dr. Harding just shared. It's difficult for us to get reimbursed as somebody's aging in place, as their needs change and as they may require increased nursing care or even one-to-one staffing as their healthcare needs really decline. So it is very difficult for us to get authorization for those types of services. Ultimately, in our case, we provide them anyway because it's what the person needs, but that's part of the reason that we're operating at the loss. And I would also like to add at Beechwood, we are credentialed with Medicare as well. I know that's part of this debate, so it's not a silver bullet answer to, bill Medicare first, because we are doing that for the services that do apply for Medicaid coverage.
Thank you. I know Ms. Masters has a comment she wants to add.
Yes, thank you. If you would indulge me to go back to an earlier conversation with the physiatrist team, there was a comment or question about getting information out to families and survivors from the hospital experience and on. And there is actually a program developed through the Brain Injury Association of Pennsylvania. I'm part of that program. It's called Ambassadors. And we get referrals from facilities when they have someone in their brain injury unit. And we get contact information for their family members. And those of us who volunteer have experience with brain injury, and we reach out offering them a packet of information that BIAPA then mails to the family with lists and stack cards of resources such as NRFP. And we also sign them up for the Brain Injury Association's newsletter via email. And so there is a program that could we connect with more facilities throughout the Commonwealth, we might be able to reach more people and more families and direct them to the resources that they need.
Thank you so much. Thank you. Let me just say, I appreciate the journey to better understand what's happening on Pennsylvania's brain injury landscape. Over the past 2 sessions, we've been able to really explore aspects of brain injury care, including insurance coverage options depending upon the circumstances of the injury, the impact of delayed diagnosis and treatment, and the long-term consequences for survivors. We've also been able to see the devastating effects on individuals and their families. And so with the right supports and the therapies, survivors can thrive, but access to care relies on strong, sustainable workforces as well as ensuring qualified professionals who are available. And that must remain a priority. I'd like you to know, though, this is just the beginning of this work. It is not the end. We will take time to reflect on the valuable insights we've gained, those that have been generously contributed by those panelists in the past 2 sessions. And what we've learned will guide our efforts to strengthen brain injury services across the Commonwealth. And so I, again, want to say thank you for your presentations and for the work that you do. Chairman Heffley, do you have any closing remarks?
I just want to thank all the panelists. Thank you, Chairman Williams, for holding these hearings, and for all the committee members for their questions. Obviously, there's an opportunity here how we can better serve this population at the state. I do want to commend Ms. Farry for being here, and just say it was about 2 years ago we had toured the Woods facility, and just what a phenomenal facility. And you see the work that's being done, and you really see kind of where the rubber meets the asphalt in a sense, as far as how those services impact lives. And so it is important, and I look forward to working on some studies and some legislation going forward to try to get you the funding that you need to continue to work that you do. Thank you.
Thank you, Chairman Heffley. For your time, for your insight, and for your expertise, I want to say thank you. I look forward to talking with you in the future. This meeting is now adjourned.